Hello, everyone who's joining us here today from all across the world. My name is Bilal Hafiz, and welcome to the PEARLS Lecture Series of 2023. I'm a third-year medical student at the University of Melbourne, and I'll be your host today. And before we get started and I introduce our speaker today, we'll quickly talk about PEARLS as an organization. So PEARLS stands for POCUS, for Emergency and Acute Care in Resource-Limited Settings. So last year in August, the inaugural PEARLS course was run in Port Vila, in Vanuatu, where Vanuatu physicians received handheld ultrasound probes to plug into their devices. And they took 3 days of rigorous ultrasound training program from a visiting team of physicians as well as sonographers, including Dr. John O'Henry, who's not here today, but Joe McCann, who's here today and is on the ground in Tonga as well, doing the second PEARLS course as well. So after these courses, our physicians, our alumni of PEARLS, they continue to receive feedback via remote imaging reviews. And then since then, the PEARLS lecture series was also born into place to make sure that we can continue supporting doctors from these resource limited settings within their emergency and acute healthcare provisions. So today we'll kickstart our fourth lecture, being POCUS in Pregnancy, given to us by Dr. Grace Wanijiku. A little bit about Grace. So she's an assistant professor of emergency medicine in the division of global EM at the Alfred Medical School of Brown University, and works clinically at Rhode Island Hospital and the Miriam Hospital in Providence. She's also affiliated with the Kenyatta National and Aga Khan University hospitals in Kenya. Grace completed a 2-year fellowship in acute care and critical care ultrasound at Yale University as well, which combined a MPH in global health at the Yale School of Public Health. Dr. Wanijiku, welcome. We really appreciate you taking the time to meet with us today and give us a lecture at 3 a.m. your local time. Just goes to show how passionate you are about ultrasound education and with the goals that PEARLS has as an organization as well. Now, before you get started with your talk today, I was hoping you could perhaps shed some light on your journey within ultrasound and how you make that a part of your clinical practice today.
Well, thank you so much, Bilal. Thank you for your invitation, and thanks everyone for tuning in to listen today. It really is an honor to be involved in your program. I have been interested in point of care ultrasound for a while. I trained for emergency medicine. Actually, even before I started emergency medicine, I was introduced to POCUS as a medical student. I did a 2-week rotation that I really loved, and I continued doing that during residency. But I feel like what really cemented it for me is that during my final year as a resident, I got a chance to go back to Kenya, where I'm from, and work with an organization called Emergency Medicine Kenya Foundation, which at the time had started a training program that really kind of drew trainees from across the country, for small clinics, small hospitals, and we had this training program that I got involved in. I got to travel across the country and really meet with healthcare providers who were trainees, to kind of see what they were, how they were doing, what challenges they were having. And I think that that rotation and that experience really cemented that this is what I wanted to do, just to see, as I'm sure all of you are aware, just the power of point of care ultrasound out there in the frontiers where there isn't much else. It really shines. And I think I was also very inspired by these doctors who are, working really hard, very long hours, very little to work with, but really incorporating ultrasound in their work. And so that kind of is what kickstarted my journey. I started to do a lot of ultrasound training programs and also trying to do ultrasound related research just to see how we can be better at creating programs, at sustaining them, at making sure that we meet our educational goals, etc. So that's what my journey was like.
Awesome. Well, thank you so much for that insight. It's very inspirational to hear, and seems like you've done some great work. I'm really excited to listen to your talk today. So yeah, whenever you're ready, please go ahead.
All right. So thanks again. I'm gonna get into it. So let's see. Just gonna make sure. Okay. All right. There you go. All right. So we're gonna be talking about point of care or what I call focused obstetrics ultrasound today. If anything is confusing or if anyone has any questions, please feel free to stop me at any time. And in terms of relevance, like why do we care about this? Why is this topic important? Data, basically WHO data from 2020 showed that in 2020, approximately 800 women died early or died from preventable causes related to pregnancy and childbirth. And that basically comes down to approximately a woman dying every 2 minutes for complications related to pregnancy. So this is a pretty high risk area, and the use of ultrasound can help in some ways mitigate this mortality and morbidity. Most of these deaths occur, as we know, in low resource settings. And in the African region where my work has been focused, we find that obstetric scanning is the #1 point of care ultrasound application. So this is pretty much very much a key topic, at least where I work. The objectives today, we're going to be going over ultrasound in first trimester, and I'm going to be focusing on transabdominal scanning. We're also going to review ultrasound in the second and third trimester, and throughout, we're mostly just going to be focusing on emergent and acute indications. So we're not going to get into, definitely not a detailed obstetric scan, but focusing on the things that should flag patients for consultations or for referral. And please stop me at any time. So what is the purpose of ultrasound in the first trimester? The purpose is we want to do it in order to confirm intrauterine pregnancy. We want to establish gestational age as accurately as we can. So in the first trimester, gestational age will be at its most accurate. It gets a little, the error margin increases the further you go along the pregnancy. So if we can establish and document gestational age in the first trimester, then it's preferable to do that. We also want to look out for multiple gestation because these are women who should be flagged for close follow-up. So preparing to do a first trimester scan, I'm a big fan of putting the machine on the right side of the patient. I'm right-handed. Some people who are left-handed like to put the machine on the left side of the patient. And then make sure that your machine is on B mode or 2D mode. And it's always, it's important if you have the OB setting to make sure your machine is on the OB setting. And this becomes important later when you're doing fetal biometry and making measurements because the machines are set up to do the measurements for you. I also recommend when you start scanning to always set the depth to maximum. And this is to make sure that you don't miss anything when you get started, and you could always adjust and reduce the depth later. Drip the patient and apply a generous amount of gel to the area of interest, and then grab your curvilinear probe. If you don't have a curvilinear probe, you can use the phased array or the cardiac probe as well. We're going to start with transabdominal transverse view. So this is where you place your probe above the pubic symphysis, making sure that the probe marker is towards the patient's right. So as you can see, this gentleman here, he has his probe right above the pubic symphysis, and this is the probe marker here facing the patient's right. When you do this, the internal landmark is going to be the bladder, and the uterus will be the area of interest. And when you see these two, then you should fan caudad and then cephalad until the bladder disappears in both directions. So what does this look like? So this is the transabdominal transverse view. The probe marker is facing the patient's right. So this is the patient's right, and this is the patient's left. This is the bladder anteriorly here, and this is our key landmark. And the uterus is here, posteriorly to the bladder. So then we're fanning back and forth, cephalad and caudad, until the bladder disappears in both directions. All right, so then after that, the next view is a transabdominal sagittal view. The probe is still above the pubic symphysis, but this time the probe marker has been rotated to face the patient's head. Once again, the bladder is going to be the internal landmark for this view, and the uterus is your area of interest. And once you find this too, then you fan to the patient's right and then the patient's left until the bladder disappears in both directions. So this is what that looks like. This time the probe marker is facing towards the patient's head. So this is cephalad and this is caudad. We have the bladder here, and this is the uterus right here. And you can see the vaginal stripe coming up over here. So then kind of the animated version of that. This is the bladder here. This is your key internal landmark. This is the uterus. And we're basically paying attention to this bladder uterus juxtaposition and looking all the way around the uterus here to make sure there's no free fluid around it. Okay. All right, so those are the two views. So we're going to talk about how we define an IUP or an intrauterine pregnancy. How do we define it? So we need three things. We need a gestational sac, we need a yolk sac, and we need a fetal pole. So as you can see on this image here, we have a gestational sac here. We have a yolk sac, which is around here. It looks like a little Cheerio. And we have a fetal pole. And if you're able to see the heart kind of flickering within the fetal pole, if you can see a fetal heart rate, it confirms that you have a live IUP. And this is usually very reassuring, especially early on when mothers come in and they're not sure, or they're bleeding, or they have pain. If you're able to visualize a fetal pole and see a heart rate in there, then it shows you that you have a live IUP. Right? I'm going to just try and move this a little bit to the side. So defining IUP, once again, there's this concept of the endomyometrial mantle, and this refers to the distance from the gestational sac to the edge of the myometrium. So this area here, you have to have at least above 5 to 7 millimeters between the gestational sac edge and the edge of the myometrium here. If you have anything less, like in this picture where it's 3 millimeters, then this is likely, or this will be a diagnosis of an interstitial ectopic or a corneal ectopic. So the endomyometrial mantle has to be more than 5 to 7 millimeters for you to have a normal IUP. Please let me know if there's any questions. I feel like I may be going too quickly, but let me know. Please stop me at any time if there's any questions about that. So you can see the mantle here. You have a really nice, thick myometrial mantle here. This one is an interstitial ectopic right here. Okay, so IUP is intrauterine pregnancy versus non-definitive intrauterine pregnancy. So at which instances do you declare an IUP versus an ND-IUP? So we talked about what you need to be able to declare an IUP. So anytime you have an ND-IUP, three things could be happening. It could be too early to tell. It could be that the patient has an ectopic pregnancy, or it could be that they're having a spontaneous abortion. And so how do we tell between those three things? So we're going to go through some cases to discuss this. So this is a transvaginal view. You have your bladder here, you have your uterus, and inside here, you can see something that looks like a gestational sac. It has two rings around it, but there's really no IUP. So this is a special case of an ND-IUP. And this is called a double decidual sign. And this is a sign of early pregnancy. This could just mean that you're imaging a little bit too early. It's too early to be able to see an IUP intra-abdominally, or trans-abdominally, I mean. This is another case where you see the uterus here. You have this large gestational sac, but there's nothing in it. So this is a special kind of ND-IUP as well, where you have a gestational sac that's large, but there's nothing in it. Sorry. It's larger than 18 millimeters, but there's no yolk sac, there's no fetal pole. And this is what's known as an embryonic pregnancy or blighted ovum. Okay. So we're going to go through a couple of cases here. So the first case is a 34-year-old female. She's coming in, she has low abdominal pain, she has vaginal bleeding, and she tells you her last menstrual period was 8 weeks ago. So then you stabilize her, send off some blood work, and grab an ultrasound. And this is a transabdominal transverse view with the bladder anterior here. And you see the uterus in the back here, and then there's just a lot of free fluid around it. All right. So then the next thing, okay, so this is the same thing, lots of free fluid. And this image, it's recommended that anytime you see free fluid in the pelvis, that you do a right upper quadrant fast view. So this is the liver, this is the kidney, you see some free fluid there. So this woman likely has an ectopic pregnancy, or has an ectopic pregnancy really until proven otherwise. And she's bleeding so much that you can actually see some blood in the right upper quadrant. So this is someone who's going to need to go and have surgery. So anytime you see fluid in the right upper quadrant, there's not going to be any medical management of this patient. This is a patient who's bled enough from a ruptured ectopic that they're going to need to go to the operating room. Case 2, a 22-year-old female. She comes in with left lower abdominal pain. She doesn't remember when her last menstrual period was, and she says there's no chance at all that she's pregnant. That's always the case, no chance whatsoever. So then you do your stabilization, you draw your blood work, but you never wait for the blood work to come back. You do an ultrasound first. So then this is actually, it's a little bit of a confusing view, but this is a sagittal view. The bladder is right here. And this is all free fluid. This is all free fluid around the uterus here too. All right, so this is another case of a ruptured ectopic. And it's an ND-IUP because there's no IUP in there. There's just a lot of blood around it. So ectopic is an ND-IUP. There's free fluid in the pelvis, and there's a positive beta HCG blood test. But once again, we're going to talk about it later, but I always advise to not wait for this, to always ultrasound first. So this is a different areas in which you can get an ectopic pregnancy. Case 3, 23-year-old female, she's 12 weeks pregnant. She tells you that she already had an ultrasound confirming an IUP 3 weeks ago, but now she's coming in with heavy vaginal bleeding and she has cramping as well. So then stabilize, get your blood work, grab your ultrasound. This is the transverse view. This is a bladder, and you see the uterus posteriorly here. And this is an ND-IUP. We don't see a gestational sac. We don't really see anything in there. And then you go for the sagittal view. And once again, we don't see an IUP. And in this area here where the cervix is, we just see a lot of heterogeneous material there. So these are just a closer view in the cervix. There's no IUP. So this is a case of a spontaneous abortion. So I just wanted to come back and emphasize when it comes to beta HCG testing, there's this concept of beta HCG discriminatory zone. And this is a serum HCG level above which an ultrasound is expected to detect a viable IUP. So you need your HCG level to be above 6,000 or above in order to visualize an IUP transabdominally, and 1,500 in order to see an IUP through a transvaginal ultrasound. However, an ectopic pregnancy is a failed IUP, and it can present at any beta HCG level. And so sometimes you'll see some people telling you that, oh, wait and see what your beta HCG is to figure out if you should be seeing an IUP, yes or no. But this is the reason why I say that you should do an ultrasound first. Don't wait for the beta HCG, because you can have a ruptured ectopic at about 10 weeks or 8 weeks with a beta HCG of 500 or a beta HCG of 700. And this is because an ectopic pregnancy is a failed IUP. And so the beta HCG will not double every 48 hours in the same way that a normal or a viable IUP would. I hope that makes sense. So this is just my thing that I always say, ultrasound first, especially if a woman comes in, she's unstable, she has abdominal pain, she is bleeding. Once you stabilize her, send off your blood work, do your ultrasound, because if she has free fluid and she tells you she hasn't seen her period in the last 8 weeks, she has a ruptured ectopic. It doesn't matter what her beta HCG number is. All right. So let me know if there's any questions about that. All right, so we're gonna move on along to fetal dating in the first trimester, and you can date using the CRL or the crown rump length. So you have to be in your OB setting, and you're basically putting your caliper from crown to rump, and this machine will calculate the gestational age for you. Okay, you can also use the gestational sac on the OB setting, and it will calculate the gestational age here for you. Okay. So then moving on to fetal heart rate. Once you see a nice fetal pole there, you can see there's a little heart flickering there. We have a live IUP and we would like to check the heart rate. You can do so by putting the M mode cursor over where you're seeing the flickering. And when you do that, it's going to show you these, it's going to result into these peaks. And depending on the machine you're using, this was a Philips that I was using, then the measurement it's made, actually I did not make the measurement very well here because it should be 2 beats peak to peak. So you measure from one peak, you skip one, and you go to the other one. And if you're on the OB setting, it's going to calculate the fetal heart rate for you. This one is just a slide to emphasize that we should not be using Doppler to determine fetal heart rate. And that's because of this principle of ELARA, or as low as reasonably achievable. So anytime we are using radiation, we really don't want to be transferring any energy to the fetus. And using Doppler kind of transfers a little bit of energy that you don't really need. And so anytime you're doing the fetal heart rate, you should use the M mode. It's always M mode. Don't use Doppler unless you're doing very advanced cardiac work, which is not, it's not us. It's not emergency care folks or acute care folks. All right, so always fan through anytime you're imaging, fan all the way through in the transverse and in the longitudinal plane to make sure that you don't miss a multiple gestation. Because once again, depending on where you are, like in rural Kenya where we work, we want to flag these women early enough to make sure that they have close follow-up. Right. So that's all I have for first trimester. Any questions? I'm going to just pause for a second before we move to second or third trimester. Anyone has a question at all? I'm not keeping an eye on the chat, Bilal. So if any questions come up on the chat, please let me know.
Of course, no worries.
Okay. So then if there are no questions, we're going to move on to second and third trimester. All right. Okay, so the indications for ultrasound in second and third trimester is to determine the fetal presentation, to perform fetal dating, to check the fetal heart rate, also to look for fetal number, determine if a patient has multiple gestation, understanding that especially in rural settings in Kenya where I work, a lot of women don't present in the first trimester. Most of them will present in the second or third. And so there will be women who have multiple gestation that do not know that they have it. And so doing an ultrasound will be very helpful. Placental location we're going to talk about, and amniotic fluid evaluation. Okay, so preparation for this second and third trimester scanning. Place the machine on the right side of the patient if you're right-handed. If you're left-handed, there's some people who prefer to have it on the left side of the patient as well. Make sure your machine is on B mode or 2D mode and in OB setting. And this is to help with your calculations later. Always set your depth to maximum. Some people will say dive your depth. Always dive your depth when you're starting to make sure you don't miss anything. And once you see your area of interest, you can always adjust. Grab your curvilinear probe or the abdominal probe. If you don't have it, you can use your cardiac probe. Drape the patient and apply generous amount of gel to where you're going to be ultrasounding. I pay very close attention to draping when it comes to imaging pregnant women. It's also very important to, especially for the women who are more advanced, to take a pillow, a wedge, or a towel and put it under the patient's right side in order to offload the IVC and prevent IVC compression. And always ensure that the patient is comfortable throughout the scan. All right, so we're going to talk about fetal presentation first. So the fetal lie is the relationship of the fetus long axis to the maternal long axis. At term, 90% of all fetuses are going to be in a longitudinal lie. So these two first pictures, this is 90% of all presentations at term. Of these, 3% will be breech. So 3% will be in this area here. So the rest of them, the majority of women after 34 weeks are going to be in a longitudinal lie with the head down or with a cephalic presentation. So if you're imaging someone at 34 weeks or above and they are non-cephalic, this is a cause for consultation or referral. And it actually makes it difficult to do other aspects of this scan if the patient's head is not down. So anytime past 34 weeks, if you're non-cephalic, your ultrasound is going to be indeterminate, and it means that this patient should go for a formal ultrasound and they should be referred. So the technique, this is basically, I think that second and third trimester can be just intimidating for a lot of people. It was for me, because as an emergency physician, we do a lot of first trimester because that's in our wheelhouse. But when it comes to second and third, it just is very intimidating. It's like, okay, Grace, where do I start? So you always start above the pubic symphysis with your probe in the transverse orientation. So always go there. That's a good place to start. Place your probe in the transverse orientation above the pubic symphysis with your probe marker facing the patient's right. So then move the probe caudad towards the patient's feet until you see your bladder, and that's going to be your internal landmark. And then when you see that, you either move your probe cephalad or you can fan cephalad until you see the fetal skull. So this is what that is going to look like. So I started off looking at my bladder because I wanted to make sure that I have my internal landmark, and then you move your probe up cephalad towards the patient's head in order to visualize the fetal skull. So this is a cephalic presentation. Okay. Just looking a little closer at the fetal skull, because anytime you see it, I want to make sure and convince myself that I'm looking at the fetal skull and I'm not looking at the abdomen or something else. So you want to make sure that you can see this very bright hyperechoic oval shape, the fetal skull. And also very important, you want to be able to see the falx cerebri. The rest, maybe not so much. You can see the thalami, but as long as you can see the skull and you can see the falx cerebri, then you know you're looking at the fetal skull. All right, so initially when I saw that structure, I really kind of wanted to fan through and make sure that I'm looking at the fetal skull. And there's my falx cerebri there. It kind of comes and goes out, and you can see the two thalami on either side. Two thalami on either side, and the falx cerebri goes through here. There it is. So then I convinced myself that this is a fetal skull and that it's a cephalic presentation. All right, so moving on ahead. Okay. And once you're here, if you have a good image of the fetal head, you can actually freeze it and use it to calculate gestational age. And you can do it in two ways. So you can perform fetal dating with BPD, or the biparietal diameter. And here's your fetal skull again. You see your falx cerebri here. Here are the two thalami on either side. And you basically drop your calipers down, making sure that you're making 90 degrees with the falx cerebri. Right. And when you do that, the other thing that's important to do is to make sure that you use the leading edge technique. So that means that your calipers are going from the outside of the skull to the inside of the skull, making 90 degrees with the falx cerebri. And if you're in the OB setting, then the machine is going to calculate the BPD for you. Okay. You can also use the head circumference to calculate the gestational age. So this is basically just tracing. You press on the ultrasound and ask to do the head circumference and just trace the outside of the fetal skull, and it's going to automatically calculate the gestational age for you. All right. Any questions about that? I wanted to just go through that because, if the head is down and you found it and you have a good picture, you can just freeze it and use it to date. All right, so moving on ahead, we're gonna go to the fetal heart rate. So you started above the pubic symphysis with your probe marker facing the patient's right. So then the next move is to basically rotate your probe, and now you have the probe marker facing the patient's head. So after visualizing the fetal head, change the probe from a transverse to a longitudinal orientation. When you do this, because you had the head down, it's going to allow you to visualize the fetal spine. And then you move the probe cephalad while following the fetal spine, and you will then encounter the fetal heart. And then you document that you can see it and that heart activity is present. So what does that look like? So as you can see, this woman, this trainee I was training with, she has a probe marker now still above the pubic symphysis, but she has a probe marker towards the patient's head. Right. So what that looks like, I am starting with the image I had in the transverse view, and I'm slowly moving towards the longitudinal view. Right, sloping back and forth, but I'm basically going from transverse to longitudinal view. And what comes down here is that the fetal spine is down here and the ribs are right here. And you can start to see the fetal heart coming through right there. Okay. All right. Okay. And then to obtain this picture, all I did was just to follow the fetal spine cephalic. So you just move your probe a little bit towards the patient's head, and you're still on that longitudinal axis. So this is the patient's head here. This is the patient's feet. We have a cephalic presentation. This is the fetal head. You see the spine here, the ribs are here, and the heart is going to be coming through there. So there you go. A really nice fetal heart rate there. You document that it's there. And then if you want to calculate, you can use the machine to calculate it for you. So if you're in the OB mode, then just, if you're in the OB setting, then just click M mode and drop the cursor over where the valves are flapping. That's gonna be where your M mode cursor is. So on this picture here, the M mode is going through where the valves are opening and closing. It gives me this tracing, and then it's going to be, the measurement is going to be a 2-beat peak to peak. So I place the cursor there, you kind of skip 1 beat and you go to the other beat. It's a 2-beat peak to peak, and it's going to give me a heart rate of 157. So anything between 120 and 160 is normal. So you can do that. You can use your ultrasound to calculate your fetal heart rate. If you don't want to do that, you don't have to, and no one is going to judge you if you don't want to. You can basically just note where the heart is, where you found it on ultrasound, and just grab your fetal monitor and place it right there. Right. And then it's going to calculate the fetal heart rate for you. So that's absolutely normal and fine to do, because I feel that using M mode sometimes can be stressful for people. The baby is moving around a lot and you just cannot keep it. It can be quite stressful. So if it's stressing you out a lot, just note where the fetal heart rate is and use your daptone and place it right there, and it's going to give you the number. All right. So moving on, determining the fetal number to see if you have a multiple gestation. Continue to follow the fetal spine. So you're on the longitudinal, as you can see this doctor, she is still on the longitudinal orientation, and she is following the fetal spine up towards the fundus. So follow the fetal spine all the way to the fetal pelvis. And then when you get to the fetal pelvis, fan in both directions to make sure that you don't see a second head there. So the fetal spine tends to be a very key landmark. You found the head was down. We follow the spine up toward the fundus. And when you get to the fundus, we fan again to make sure that we don't see another head. Okay. And then depending on where you came up through, if the baby was more on the right side, if you follow the spine, you're going to go up all the way on the right side towards the fundus, and then you fan, make sure you don't have a second head. And then you take your probe all the way down on the left side and scan through to make sure that you don't see another head. Right. So what does that look like? Hope that makes sense. So the head was down here. This is the fundus here, and we're just scanning, kind of slowly going up and following the spine and heading towards the fetal pelvis, which is going to be this area here. And this is what it looks like when we get to the fetal pelvis. This is the feet. The pelvis is around here, and we're fanning back and forth to make sure that you don't see an additional head there. And when we see that there isn't a head, then we just kind of go all the way around the fundus in the opposite direction. Make sure we don't see any other additional heads. Okay. All right. We'll stop that. Okay. Trying to move to the next one. Okay. Ask me any questions at any time. All right, so then we're going to move on to placenta location. And like we talked about before, only evaluate this if your fetus is vertex, especially if you are 34 weeks or more. If you have a different kind of presentation, or if you have multiples, your evaluation of the placenta is going to be limited. And so in that case, it's going to be indeterminate. So this teaching is really only when the fetus is in a cephalic presentation. So once again, the process is locating the fetal head like we did before, then change your probe orientation from transverse to longitudinal. And then in this case, we're keeping our probe on that longitudinal and basically sliding the probe towards the fundus along the linea nigra until you encounter the thicker and fluffy appearing soft tissue structure, which is a placenta. So as you can see what this gentleman was doing, he started off over the suprapubic area, and he's basically sliding his probe in a longitudinal orientation along the linea nigra all the way up to the fundus. And you can feel free to slide, to the right or to the left in order to identify the placenta. So what does that look like? Right, so we started here. We're on the longitudinal view. This is a cephalic presentation. We can already see some part of the placenta here, but the teaching is that we should kind of follow it. We should slide the probe along the linea nigra all the way up to the fundus. Okay. So then so this is what it looks like. I'm sliding my probe towards the fundus, and I'm looking at this fluffy structure here. And you can see, so this is cephala, this is a patient's head, this is the patient's feet, this is anterior, and that's posterior. So most of the placenta is anterior, and you can see the cephalic edge of the placenta here. So this is the fundal edge here of the placenta right there. Okay, so now that we found the fundal edge, the next step will be to find the caudal edge of the placenta. Right. So this image is just showing the fundal or the cephalic edge of the placenta right there. That's where it kind of disappears into the myometrium. You see it right there. Okay. I just have a lot of, okay. So then after we locate the placenta, we want to slide the probe caudally. So then we're going to slide the probe back towards the pubis symphysis to locate the caudal edge of the placenta. This is where the placenta thins out into the uterine wall. And the goal and what we want is that we want to see this placenta kind of where it disappears. We want to make sure that this placenta is cephalad to the fetal head, right? We want to make sure that this placenta is north of the fetal head, because that means that it's a safe area. We want to make sure that this placenta is not inserting all the way down here, all right? Because then that would be very concerning for placenta previa. I hope that makes sense. All right, so then, right, so then I'm sliding back towards the pubis symphysis, keeping an eye on the placenta here. All right. And then this kind of looks like we're getting to the caudal edge here where the placenta inserts. So then my goal is to make sure that this insertion site of the placenta is cephalad to the fetal head. Right. Once you find the caudal edge of the placenta, then the move is to slide your probe right and left to ensure that the caudal edge of the placenta is cephalad to the fetal head. I've said that like 10 times, but it's very important because that's a way we make sure that the placenta is located in a safe area, that we're not at risk of placenta previa. So what I'm doing here is that I'm sliding the probe to the right. Once I find the caudal edge, I'm sliding my probe to the right and to the left because I really want to see that the insertion site is there and the fetal head is below it. So that's safe. That's what we want to see. All right. We're going to move on ahead. Amniotic fluid evaluation. I won't spend too much time on this one, but the way to do this and the quickest way to do it is to divide the maternal abdomen into 4 quadrants and scan with your probe in a longitudinal orientation and a vertical plane. So your probe marker is facing the patient's head and you make sure that you're at a nice 90 degrees and that the probe is not angled to the side or to the side in one way. And then what we do is that we perform a grid search. So we're going right to left in each quadrant, looking for the largest fluid pockets without fetal pads. So it's going to be the deepest fluid pocket that you can find that doesn't have a foot in it or doesn't have an umbilical cord in it. It has to be completely free of any fetal part. So once you find that, you freeze it and measure the deepest vertical pocket. And then the total measurement for all 4 quadrants is referred to the amniotic fluid index. So what this looks like is that I started in the right lower quadrant, and you're just doing a grid search, looking through that quadrant, finding the deepest pocket here. And once you find it, freeze and make a measurement here. This one comes to about 4 centimeters. And then this is the right upper quadrant. This is the deepest pocket I could find, was about 4 centimeters. Left upper quadrant was about 5.2. And the left lower quadrant was about 4.49. So then I add all of this and it's going to add up to about 17, which is normal. Anything above 25 will be abnormal. So 17 is a nice normal number. So any fluid pocket that's less than 2 centimeters counts as 0. Any 2 pockets with over 2 centimeters, over 3 centimeters is normal. If you have a single pocket that's more than 8 centimeters, or if you have a total AFI of 25 or more, that's diagnostic of polyhydramnios. So if your fluid pockets are less than 2 centimeters kind of throughout, that's oligohydramnios. And if you have one single pocket that's more than 8 centimeters, or if you added up everything and it's more than 25, then that's polyhydramnios. And this obviously, as with everything, it's going to be taken in context together with everything else that's happening to the patient. But oligopolyhydramnios is going to be a concern that's going to basically trigger this patient to be referred for consultation. All right, so that's what I have for today.